I'd like to present today Dr. Francine MacInnis. Welcome. She's a specialist in cognitive behavior therapy. She has over 20 years of experience working with clients. She works at the Emotional Health CBT Clinic located at the Queen Elizabeth Health Complex. She's here today to talk about depression, and the treatment that we want to talk about today is cognitive behavior therapy. So let's all welcome her and enjoy our evening. Thank you very much.
Hello, everybody. Thank you for having me. We're going to talk about depression tonight as we wait for spring to upload. Slowly but surely, the better times are starting to roll in. I've put together some slides to provide information, but mostly what I want is that we addressed the questions that you might have about it. So this is more to get the conversation going, but if you have questions along the way or things you'd like to interject, feel free to do so. Don't mind interrupting me. It's actually often pointed to me that's a challenge to interrupt me, so it won't throw me off my game if you have a question to raise it. Also, I think most of you, I caught you on the way in. There's little yellow stickies on the table up front. Those are your questions that I would like to get to before you go, so I've tried to drink those in before starting, but if you have some along the way, you can stick them up there too. So hopefully we have you go home with a point of information that's useful to you. All right, so I'm just going to get right started, but as I said, it's always more fun when you participate, so feel free to jump in as you have thoughts and questions. All right, so just a few technical pieces of information. What is depression formally? And the reason I kind of call it out as what is it formally called is that it's kind of a colloquial term as well. You know, I have a 13-year-old son and I hear how they talk and they say, oh, I'm so depressed, X, Y, Z, and it's like, okay, you can't be throwing that word around like that. So it does have a colloquial usage, but I'd like to talk to you about more formally what it is, because often people who are coming here are concerned about themselves or somebody that they love and they want to know, am I really dealing with this? So I'm going to go through the criteria so you know the difference between when people say, you know, oh, I'm feeling depressed. Maybe I can put it to you. What do you think they're saying when it's thrown kind of colloquially around? They're sad, it's a bit of a rough period. So it could be situational difficulty, or it could be their mood. Like everybody has some depressed mood, right? It happens to everybody. And so we want to be able to distinguish a situational rough time or a sad or a low mood from having a major depression. So we'll talk about what that really consists of. It's part of the depressive disorders cluster, which you don't need to know, but there's a diagnostic manual that we use to formally diagnose. And so one of the questions that people have is, or what are the criteria to know that the person would meet the diagnostic criteria for a formal diagnosis? So I'll tell you what those are. And it needs to be distinguished. So tonight we're talking about what's called major depressive disorder. And one of the things that professionals will do, will try to distinguish that from other maybe related disorders, for example, bipolar disorder, or what used to be called dysthymia. It's now called chronic depressive condition, because the treatment varies, the experience varies to an important extent, and the treatment varies. So tonight we're going to be focusing on major depression, but one of the things is to try and make sure that it's not something else that's related to that. So we'll clarify at least the major depression tonight. So I've got the symptoms for you here. We already caught one of them, which is sadness is sort of the one that's most associated with depression. But one of the things I find most useful to point out when I'm talking to people who are connected to the person I think might be depressed is that irritability is one that's often we miss. that somebody becomes significantly more irritable, we think, why are they angry all the time? And for many, that is the sort of the telltale sign that they've become depressed. They're less inclined to express sad, and they become much more irritable. So that's something, just as a little flag to you, that I'll say a few more words about. It's particularly when it's a lot more than usual. So we all know also grumpy people who are just kind of grumpy and irritable by nature, and you're not allowed to point fingers at anybody in the audience when we say this, okay? Including me, it's not allowed. So that you're, in all cases, you're looking for something that's different than usual. So it's especially when somebody who's not accustomed to being irritable starts becoming irritable a lot, then you think, I wonder what's going on. And it's not people's usual associations. So that one I point out, I highlight to you. Loss of interest and pleasure is another one that you probably have heard about, where things don't feel as good or aren't as interesting as they used to be. This is one that's kind of subtle. I think it's a harder one for people to pick up because it's often a little more insidious, a little bit more over time, and it's a little bit harder to put your finger on, but it's one of the criteria. And what you want to think about is the whole set of criteria, and I'll show you next that you have to hit a certain number of them, and that one's a little bit more subtle. So when you put it together with others, you get the picture that depression is going on, was by itself you might not have noticed that, hey, this is part of something more. Weight loss or weight gain or changes in appetite in and of itself don't mean something, but again, part of a bigger picture can be useful. Insomnia or hypersomnia. More commonly, people will report, in kind of associatively, more sleeping rather than less sleeping, but for some people it wakes them up in the night, or their sleep is disrupted when normally their sleep is pretty regular, so that can be another helpful cue that something's going on. Psychomotor retardation or agitation, so more and less energy and activity, or another couple more, often obviously reduced energy and activity is what we associate with it. Fatigue, worthlessness or inappropriate guilt. I find this one is, to people who are trying to see it in others, one of the most useful ones, because sometimes you can catch a little corner of it and realize, boy, this person is getting really hard on themselves about what seems like a regular or even small thing that's happened. And this is I find this one easier to pick up on, especially if it's recurring, that's like disproportionate reactions to normal situations, or even sometimes what feel like relatively minor situations. Inability to think, concentrate, and decide. Uniformly, clients that I work with will report on that when they think, hey, normally I'm pretty good at remembering stuff and I'm organized, or I'm able to pay attention or read or work on a document or some piece of work longer than this, and they start feeling like what's going on. So that's something they might you can watch out for, that they might actually be expressing, because that's a point of frustration. And you can imagine how they feed one another. When you're not feeling too great and then your concentration and memory is not good, they can kind of add up to feeling worse if we don't get on top of it. And recurrent thoughts of death. I'll talk a little bit more about that. That's the piece that most worries people, our family members, is having a sense of, when do I need to be particularly concerned? Because sometimes those thoughts of death are passive thoughts of death, of not wanting to cope, not wanting to be around anymore, not feeling valued, not feeling too burdened or too saddled, which is different from I actively want to die. So sometimes people hear things expressed that are death. They're speaking about death more, and trying to get a sense for family members whether or not they're in danger is particularly important. And of course, if ever you have any doubts, you tap into the professionals. You don't try and make this distinction yourself, but I'll hopefully try and clarify things for you as we go through. Any comments or questions about this list? No? You guys had studied before you came? Okay. All right. So important here is that you need 4 of the 9, so you don't have to have all of them to meet the criteria. And, and you have to have 1 or 2. Okay, so 1 and 2, and then at least 2 more from the list. And depression is expressed differently or manifests differently in different people. So you know that 1 or 2 is going to be there, and then you're looking to see what else am I seeing. And so I find this really useful because one or the other thing, you're not sure what's going on. Is it a tough time? Is the person feeling a bit sad? But when you start to see kind of more on the list and you're observant and paying attention to particular things, then it gets clearer. And over and above that, it needs to last for some time, a minimum of 2 weeks. So it's not a passing thing, it's something. And usually that's not difficult to meet because by the time the person themselves is noticing and the people in their family is noticing, it's been some amount of time. So it tends to be persistent before anybody calls it out. And again, most useful, and I'll make a small distinction after this, is to notice this is not their usual self. And I'm going to jump ahead to some of your questions. I'm not good at waiting on stuff, so I'm going to jump ahead a little bit. What I find most useful, because everybody has hard time talking to somebody they love about this last section here about this is unusual for this person is most helpful because you can call that out. Because often somebody who's feeling depressed is not feeling good about themselves. And so people don't want to make them feel worse by talking to them, and they don't want them to feel criticized by you bringing things to them. But one thing that helps is you're saying, this is not how you usually are. Right? So you're pointing out, this is not who I think you are. I don't think you've become irritable or any of this. This isn't the way you usually are. So it helps to be paying attention to the fact that we're even calling this out because this is not the usual them. And it's good to remind yourself and remind them of that, and that's why this conversation is being had. So just store that away for later around how do I talk to somebody else about this. Significant impairment of function. Generally the person and those around them will notice a difference. Sometimes it takes a bit of time because people can mask their functioning, like they're used to doing a lot and now they're doing less, so they're still functional. So you really have to pay attention over time to see how different this is from their usual. So somebody who's used to working 70 hours a week, who's now working 40 or 50, they're still a very functional person, but you're detecting this is different from the amount of work they would normally put in or do. Or social activity is the same. They're still social and they still see people, but a lot less than they normally would. So that helps to see that there's a distinction there. Or they're managing to function, but with a lot more effort, so it's a lot more strain. One thing we notice is that people will work, or they'll take care of their families, or they'll do the things that are kind of the critical things, and then all the rest falls off. So they won't socialize, or they'll downgrade on other activities because just covering the basic core things, they're spent. So the rest falls off. So you'll see they're still functioning, but you can see the overall picture is they don't have their usual capacity. So good so far? Yeah, we have a question.
Yes, I just thought that change in relationships with the family
was being good. Okay. You're surprised not to see it there. Okay, so the question was, or the comment was, this lady was surprised to see that social relationships or a change in social relationships wasn't on the list. And if I just go back up, I would agree with you that I almost invariably see that. And so I'm wondering if maybe where we pick it up is in the loss of interest and pleasure. is that they stop seeing people, and we'll get to the treatment later, but one of my first questions when I'm with somebody is, who aren't they talking to anymore, right? So, and how do we get them reconnected to people who are going to be a support to them, with whom they feel comfortable. So it could be in that, or a loss of activity. So they'll pull back. So people tend to pull back, withdraw, isolate, and they're often spent. So one of the things that goes are social relationships, because it's considered by many to be an extra, to be superfluous. But as we know, it really isn't, right? So one of my I work with the cognitive behavioral therapy clinic, as was mentioned in the introduction, but one of my side areas of expertise is in positive psychology. And one of the things I notice is that people who are well, so happy in its kind of broad definition, they are active in these different areas that keep them afloat, that keep them happy. And one of those areas are their social relationships. And for people who do well, they recognize that it's as important as exercise and other things in terms of staying buoyant and staying supported, staying stimulated, having fresh inputs around how you're thinking about yourself and the world. But often it's conceived of as like just extracurricular. So if you're not feeling good or if you're overwhelmed, it's one of the first things that gets thrown off the list. But I would agree that's often a telltale sign. We're on the same page. All right. So a bit more information about depression. I threw up just some prevalence information. 10 to 25% of women over a lifetime, 5 to 12% for men, and then point prevalence just means at any given time. 5 to 9% for women, 2 to 3% for men, which always sounds low to me from, I'm sure it has a little bit to do with what I do, but even just in my own professional and social circles, it feels more prevalent than that. But just to give you a ballpark idea, the symptoms can range from mild to severe. One thing to think about in terms of those rates is that often when I meet people in an intake, because I do many of the intakes for the clinic, is that people are not aware of even that they are depressed. So they realize they're frustrated or not satisfied or bumping into some obstacles. And so sometimes what we'll do is we'll do a short inventory and get a sense of the degree, the types and degree of symptoms, and they can be sometimes moderately to severely depressed without really fully appreciating what's going on. So that's something to think about, is like it might be mild, but often by the time it reaches people's awareness, they're in more than moderate to severe range, because people function a lot with mild symptoms. Only 30% seek treatment. So I think that's, a really salient point that we'd like to make, because I know many people who come to these kinds of talks are thinking about somebody in particular who they feel might be suffering from depression, and we really need people to help them into treatment, because sometimes, and you think about what it is you're suffering from, it's difficult to initiate new things. You withdraw socially and you're into your own thoughts. You're not feeling good about yourself. It takes a fair bit of wherewithal to say, hey, I think I might be depressed and now I need to find a resource and meet a new therapist. Like that all takes something, energy and initiative and concentration and focus that people who might be moderately to severely depressed, they don't feel like they have. And so I think that's one of the critical places where people surrounding them can help. Because you think about the energy it takes for any of us to organize ourselves around appointments and doing things we don't usually do. It takes additional thought and effort that they might not feel like they have. Untreated, I mean, it's the impact is very significant, and I know anybody who's got a family member who suffers from it worries about not only suffering but suicide attempts, and when they think about the most severe potential impacts, I mean, there's impacts on the workplace. It's the leading cause of disability and people not being able to be productive, which sometimes people feel quite uncomfortable talking about productivity because that's like a business cost and so on. But that's a tremendous cost to the person too, right? Like, I know when I'm not productive, I don't feel good. And most people, whatever their usual types of contributions that they like to make, whether or not that's in the workplace, in their home, in their relationships, in their communities, when they're not feeling productive, they're often not feeling good. And people often aren't able to be productive when they're feeling depressed. So the costs are very significant to the individual and to the families and to the workplaces as well. All right. Recurrence. After one episode, 60% will have a second episode. After 2 episodes, that's up to 70%, and after 3, 90% will have a 4th episode. And we're not saying this to discourage you. In fact, this is really to try and encourage people that it's really useful when it's happening to try and get them into a treatment process, because treatment really helps reduce the likelihood of relapses. Now, above and beyond relapses, the other benefit is that people build skills. So given that recurrences are normal, when people know the drill, they're more likely, when they've been through a treatment process, to understand what's happening and recognize the signs, and also have some sense of what they can do and how they re-engage. So if somebody who's been depressed and treated can re-engage the skills and a therapy process and intervene more quickly. And like I say, with clients I've worked with who have been through multiple depressions, what we want to avoid are the big dips. Right? So you might still get depressed, but if you intervene sooner, it's easier to pull back out and get back into a regular pattern than when it's really low. Treatment still works, but it takes longer and it's more arduous, and it really takes a village, right, to kind of achieve liftoff. So it's useful to think, not get discouraged about the cycles, because it is episodic and it is recurrent, but treatment is really important to try and keep those waves, the smallest they can be, but also for people to know, if I get depressed, I can get treated and I can get better again. So, because that's often a lifetime thing that people are working on. Yes?
How do you define an episode? Is it really clear that it's an episode?
Well, so what is an episode? Is that the question? Yes. Right. So, when you think about it, it doesn't kind of switch on one day and then switch off the other, right? So trying to detect where you are in there, which is part of why when we receive people, they're often beyond mild symptoms, because it sort of arrives more gradually, and it takes a bit of time often before you realize all that's happening, so that you are depressed. But when you're depressed, you meet all of those criteria, right? And there are also, you can kind of look online if you have doubt, because you'll find this information online, or you can go to a clinic or a GP to fill out a little questionnaire to get some clarity. But you'll meet those criteria. And one of the questions people had is, how long does it take before you're out of an episode? And so just to kind of weave that in, when is it over? Well, mostly what you see in good time is a lightening of symptoms, right? So you won't get full resolution for a while, but you'll see some of the symptoms start to lift or be less severe, or the suffering or the intensity to be less. How long a whole episode lasts depends on how severe it was by the time you start to intervene, so that's going to take a bit longer.
It's easy to say if I'm thinking about myself, but if I see someone, where would I see it? Because you're not observing 24 hours or 3 days, so their activity depending on the life activity.
How can you tell in somebody else is your question. Can I ask a clarifying question first? Why would it be important for the other person to know, like, what's behind your question?
If I see someone might be, so what is really to suggest
Okay. So the question is, when do I know my argument for the question is, when do I know that I should help the person, like that they need help? And I would say, I'm one to take my time a little bit to see, like, is this very different from what's usual? Like, are they having like a little bad patch? And this is situational, and when we get through a hump, like I would say, the city of Montreal at this time of year looks pretty depressed, right? Like everybody's resources are depleted, they're kind of scraping through by their nails, waiting for spring to arrive, and there is like a global thing, everybody's going through a tough period, so I would be reluctant to conclude too much in this one little period of time. Now, if I've been seeing this for a longer period of time and it doesn't seem to lift, like when you would normally expect it to lift, and you're saying, this seems like it's been quite a while now that they're not their usual self and they're not doing their usual things, and they're either more irritable or seem sad, more tearful. They react with tears more quickly than I've ever seen them react. Then I wouldn't, if it's a close relationship, I wouldn't hesitate after I've given myself a little time to watch. Like, let's say it's a month or it's 6 weeks. They're probably not fallen into a deep depression at that point. It's not too soon to ask how they're doing and maybe share what you've noticed and how are things, and kind of find out, is there something situational, or will they open up to you? Like, I would be inclined to try and say something, not immediately, but I wouldn't wait months before I would try and open up a conversation with them. Because one of the things I notice working with folks who are depressed, I'll ask them, who are your close friends with whom, like, who knows this is going on? Who knows how you're feeling? And oftentimes that's the hardest thing. It's set in for a while and they've stopped talking to people, and they don't feel like they can open up and like just pretend, like have regular conversation about just anything because they feel terrible, but they don't feel like they can talk about that either. So it's often a kind other person who tries to make their way in and open the door that they'll speak to, because they sense that this person knows they're not feeling well and is inviting them into a conversation out of kindness and empathy, and who's giving them some space to do it. Because it's a really hard thing when you've not been talking about it along the way to slide into conversation. So I'll often say, like, there's really nobody who kind of guesses that maybe something's going on, because it's really important. Like, we're there for them, but they need to make their way back into their own social circle and expand their supports. And most often they'll signal somebody, even if it's a colleague, because you see your colleagues all the time, and they'll realize that the colleagues walked up on them when they were crying at lunch hour and stopped and it's like brought them a cup of tea or something, so to acknowledge, okay, you're not feeling so hot, how can I help? So oftentimes it takes a little encouragement and they'll share something. And then you have like a door open where you can, and they have a door open where you can speak more about it, because it's not easy to have that conversation. Did I answer your question? Yes. Okay, the good news is that, in between full episodes of depression, people resume. Mostly they resume their full activities. So people need that encouragement. They need to know you can become depressed and you can be treated, and then you can be not depressed. And that there may be another episode. So one of the things we watch out for when we're, at the end of an episode and people are doing well again, many of them know, because they've had past episodes, that they could become depressed again. And what we don't want is for them to be fearful of it. We want them to be mindful, we want them to be aware, we want them to be continuing to take care of themselves and watching for signals. But what we don't want for them is during their good times to be worried about future bad times, right? We really kind of want mindful, fulsome living in the now when you're feeling good. There's nothing worse than thwarting your good times with worrying about past bad times or future bad times. So one of those things is, for people surrounding those who may have suffered or are suffering from depression, is to squirrel away what were the signals that they were becoming depressed, because each person has kind of their manifestation of it. So when they're getting to feeling this way, what does that look like? Is it more sleeping? Is it more irritability? Is it they don't want to see anybody socially? What are theirs? And so you can be mindful, like when it happens, you'll be, is something going on here? But also, what helped? Right? So everybody has their stuff that helps them more than another thing. So for some people, their best stuff is physical. Getting moving, getting them out the door, going for walks. So if you're somebody in their social environment or in their social circle or family circle, and you know that, oops, things are starting to go down a bit, gee, we haven't been going on our walks for a while. Like it doesn't have to be subtle, but you can try and reinvigorate those things that helps, because one of the things we're going to do when we see them for treatment is we're going to do those things. So if you're off work for depression, or you're home and you're seeing your GP, they're going to ask you all the same questions. How's your sleep, and are you exercising, and how are you eating, and are you seeing people? And the reason is that when people are doing those things, they tend to get better. And when they're not doing those things, they tend to get stuck. So one of the things you can do is, when somebody has been depressed before and you're mindful of, are we approaching another episode, is like, are those signals there, and how can we get back into some of those habits that help lift things again? Because each person has I find even people who are well, not depressed, not anxious, none of those things, I think everybody has to learn what their formula is. I call them their happiness drivers. So what are those kinds of things that tend to make you feel good in life? Where, is that, I know for me that if I have a little break, if my day starts kind of careening down the hill, that's no good. I need my day to kind of achieve a gentle liftoff. So how I set up the beginning of my day makes all the difference in how I feel ongoing. I need to see people, I need to move around. No big shocker there, right? If I'm not, this is actually quite a challenge for me standing here in this one place, but so far so good. But you have to figure out, what are those things that keep you in a good place, good equilibrium. And I will tell you that most people, when we see them clinically, over some conversations, they can name you what are those things that are good for them that they're not doing anymore, that have fallen off. And that when we get them back in place, it's like you're kind of on tilt, and then we get those back in place and they tend to kind of get into a reset pattern, they start to feel better. So part of the therapy work is to get those things back and identify what those are and get those back in place. So people around them might know what some of those are too. Mean onset in the mid-20s and earlier. We see a lot of people, when we were having a little chat about it before, with the number of colleges and universities in town, not too surprising that we see a lot of people in their late teens, early 20s. Because there's just so much going on, right? Identity stuff and a lot of pressure, a lot of hormone stuff going on, a lot of identity, away from, not too surprising that we see a lot of first episodes in the late teens, early 20s. So just a few little points of information. Treatments. I'm not an expert in medication, so I won't go on at length about it, but oftentimes people's questions are about antidepressant medications. So this is treating people, as you know, chemically, whereas the therapy approach is, I think you know the distinction between the two. And so, yes, here's some information about the success rates, a 50 to 70% response to the medication. The relapse rate, however, is 60%, which is pretty high. I put down a few points here. I had a couple questions in my stickies over here about medications. What are some of the important considerations? I put preference partly because some people are really, really not comfortable taking medication. And so we try to work with how comfortable that person feels with medication. Some people are there because they definitely don't want to take medication, and they'd even be willing to do therapy to not have to take medication. Doesn't really give us a very good brand, but that's okay. We'll take them with open arms. But so some people are really, really not comfortable, in which case, one of the approaches might be, in that case, start your therapy and let's see if we can get some lift going. And then we'll put that on the shelf for right now. If we need to think about that, we'll think about that later, but I try to first work with the person's preference around medication. Other people have come, they've already seen their GP, they're on medication, they're good with that, and it's working and somebody's taking care of that. That's good too. One of the considerations, I would say from my experience, the key consideration is, are they able to respond to therapy? So whether or not that's depression or anxiety, if the person is so depressed that they can't engage with a therapy process and they can't engage with the work that therapy involves, then medication might help get some lift going so that they can engage with therapy and then accrue the benefits of a therapy process. So if I'm working with somebody for a while and they even struggle to get to the therapy, they struggle through the process, and then they really can't seem to engage in what we call the homework or the things, because you have to be doing something different for something to change. I'll be right with you. Then medication is a good time to reconsider that if you had been close to it before, because if we can't achieve any liftoff, then we're stuck in that place. So it's sometimes good to consider the mix. Yes, you had a question.
And the opposite also happened, that the medication will numb them too much, but the therapy work?
The question is, can therapy numb people too? Can medication numb them too much to be able to benefit from the therapy? I have not had any of that experience. What I will say, though, is that sometimes the person taking the medication does not like what it feels like. They might complain that they feel numb or fuzzy, and I wouldn't be in a place to name what's going on or what's happening. Sometimes what the psychiatrist or GP will do at that point is change a dosage level, or they will change the medication. Because if the person feels numb and is a lot of side effects, that's not that helpful to them. But I haven't had it where they feel too numb. Now, sometimes people feel on medication like, I'm good to go, I don't need therapy, and so sometimes they'll make a decision at that point that the mood problems have kind of lifted, and they'll carry on from there. Sometimes, we'll never force that issue, but we certainly will try and encourage to do some of the therapy work because of the relapse rate. So, the chemical effect will improve kind of how the system is doing, but they haven't learned how to do things any differently, so that when the medications are withdrawn, then they can fall back into another episode. So more for the long-standing benefits, we'll try to encourage the therapy process or both. But as you know, some people never make it to therapy; they only do the medications, and some ongoing, they just stay on the medications. But when they're working with us, we try to encourage both, or therapy until they see they might need to add medication in. I don't know if that answered your question. Ish. A little. Okay. Speed of impact. So one of the things that we think about, one of the worries always is around suicidal ideation or suicide potential. And if we hear somebody who is actively suicidal, is making plans or starting to formulate plans, and we see some of the signals and the mood is really low and it's not lifting, then we need a response quicker. Then medication is also something that we have to try and move the treatment process faster. Than medication and therapy together is something that we'll be advocating for, including hospitalization. I mean, if I'm with somebody that I don't feel I can secure their safety, then, and for example, because medication also takes time to take effect, right? So if, the person has strongly preferred not to be on medication, but the mood is low and even sinking, they're not responding to therapy, and now they're open to medication, sometimes the best place for the medication to be sorted out is hospitalized in a safe place, and then once that has been stabilized and lifted, you come back out and you keep your therapy process going, or you restart it. So, yes, question.
I have always heard that if a person is contemplating suicide, they would not talk about it. People don't talk about it. Like, my son would tell me sometimes, I think about suicide, Mom, but it's not active, it's passive. But then my brother-in-law, who's doing his thesis in psychology, tells me, if a person is really contemplating suicide, it's not spoken about. They would do it without you knowing. Is that true?
So the comment is, the understanding is, or the notion that's out there is that if people are truly suicidal, they're not going to tell you. And if they aren't truly suicidal, or they don't wish to follow through on their suicidal thoughts, they're more likely to tell you. That's kind of, I prefer not to dabble in that. So if somebody is talking to me about it, I will be inclined to delve into it, and mainly, like you said, passive versus active. So I don't act immediately on passive thoughts of suicide, where people think about dying or think about harming themselves, but they have no plans, no history, and things that they could actually act upon. Where we have to be especially careful is where they're alone a lot and they have access, and there's alcohol involved and other things that can affect judgment, can affect impulse control, where they could mistakenly do something. So even though people might be talking about it and they don't intend to, they're not intending to act, but it's sounding like it's escalating and they have plans and they have access to ways that they could harm themselves, but their judgment isn't so good and their impulse control isn't so good. It's like we don't mess around. We get into it and find out how high the risk seems to be. What I would agree with you on is that once people are convinced of it and they're just going to act, they may stop talking about it because they're just planning at that point and they don't want any intervention. So if people are, the good news is often in a suicide plan is that we have contracted with them to say, when you're feeling this way, who will you speak to? So that, and oftentimes they don't want to act. So who you're going to speak to, and sometimes enough that somebody knows how they're feeling and can be with them and can get them through that. Either short period or longer period is enough. But if they're not engaging their plan, then we take steps to get them secured, because we can't count on their capacity to control their actions. Yes.
What percentage would foresee that they will have suicidal thoughts? Like, it's not all related to depression associated with suicidal thoughts.
What other conditions?
What percentage?
Oh, what percentage? It's pretty common to have suicidal thoughts. What's less common is an action plan. And our objective is to keep it from getting to an active plan, right? So when people are extremely distressed, right, suffering a great deal, it's not uncommon to have at least passive thoughts of suicide. It's not only in the severe cases. Even in anxiety, we have people who have passive thoughts, because it's one of the things it reflects is I can't stand coping anymore. So it takes, as you know, it takes work to cope, and sometimes when it gets tough, it takes a lot of effort to hold thoughts at bay and impulses at bay and think differently. And so sometimes people get very, very tired of the efforts they have to put into coping. Like, it's not like, what they forget is it's not like that all the time, but when they're in it, it feels like extremely hard work, and sometimes they're like, I just don't want to do this work anymore.
I was just thinking that you gave a range, 5% to 20% of women suffer from depression. So in that percentage, I was just thinking how many you see.
Well, I don't know a number of what percentage has a suicidal thought, but it's pretty common that suicidal thoughts, without saying suicidal, plans to act. That would be a smaller percentage for sure. Yes, I have a question over here.
This line of questioning is really important for the family members, but I was also wondering if you could speak a little about the CBT and how it relates to the depression before we go to the question.
Sure.
Would that be good?
Sure. We're going to get to it right after this. Okay. Just so you believe me. See, it's right there. Yeah. Oh, the question was, before we get into the detailed questions, can we talk about CBT therapy in the context of depression? Thank you. Suicide prevention, I mentioned earlier that 15% can die. The best predictors are a plan, hopelessness, and previous attempt. So we're watching for all of that. Just to speak to your point earlier, when people are truly hopeless, they may stop talking about it because they've just decided they're done. But we're often tracking, and clients will mention to us that we can hear in the overall conversation where the conversation is, and we'll often think to ask, how are the suicide thoughts these days? Because we know that they've struggled with it in the past. And getting it out on the table, as a family member, don't be afraid to ask, right? Because it's an extremely difficult thing to tell your family that you've thought about suicide, right? Nobody wants to say this to their family, but sometimes they just need to say that they've had the thought. And then it keeps them feeling safer now that they don't have this shameful secret or scary secret somebody knows, so that if they say, I'm feeling it and I need your help, somebody already knows. So I think, it's don't be afraid to ask if they've had those thoughts. And if it's no, fabulous, great, right? If it's yes, it's better to know. And then that seal has been broken, that conversation can be had. Treatment. All right. So in terms of treatment approaches, I mentioned medications. Often in combination, a cognitive behavioral therapy approach is highly recommended. It remains a very demonstrated, trusted, and true approach to treating depression. It's very effective. Often in combination, as I mentioned here. And I don't know if you have run into CBT in the past. Some people have some familiarity with it, so I won't delve in detail. But basically, a cognitive behavioral approach recognizes or highlights the relationship between thoughts, feelings, and behaviors. And it all sounds very theoretical and conceptual, but I will tell you, when we run groups and we have people in, we start to give them situations, quickly they will identify with how these pieces are interconnected. And I'll just do a quick little example. Let's say we were coming in here tonight and you are part of a close community, so you might know a bunch of people in the room. And as you are closing your car door, you look over and you see somebody that you think you know. And you're waving, hi, how's it going? Nice to see you. And the person keeps straight on walking. How might you feel? Just, you can throw out your answers. If it becomes chaos in here, I'll handle it. How might you feel? Disappointed. Ignored. Insulted. Maybe they didn't see me. Pardon me? I think we covered like the main ones, right? People will feel hurt, angry, some version, and so you can see objectively it's the same event for everybody. They were in a parking lot, somebody didn't acknowledge their wave, and it can go a lot of different ways. And what is the intervening variable there that will determine how you feel? What made one person react with, I'm hurt or insulted or ignored, versus, guess they didn't see me? What you thought. How you conceived of that situation has a big bearing on how you're going to feel about it. So let's say you know that person has a hearing problem. You're more likely to interpret it as, they probably didn't even hear me. Oh, you know, Edna, she misses half of what I say. She's lovely. I'm sure she just didn't hear me. As opposed to, seems to me that's a third time, right? So that person, they think they're high and mighty and blah, blah, blah. You can hear it all getting cooked up in there. So the cognitive behavioral approach, what it wants to do is bring that out into conscious awareness, that something happens. Those are the facts of the situation. The facts are often very limited. And then what happens is it goes into the machine. And we create a narrative around that event. And then that narrative generates feelings. And then let's talk about the B of the CBT. Then let's say you felt ignored. What might happen next for you?
Check the later on if it happens that we are going to the same activity. When I will make sure that she sees me, and if it repeats itself, I will say, okay, she prefers not to be in contact today.
Oh, okay. So one potential behavioral response. Sorry, I'm making this sound all clinical, but I'm just trying to illustrate here. We're just talking about going to a talk. But so one behavioral response would be to say, test out the hypothesis. Maybe she didn't hear me. Once I get in the room, I'll see if she's there and I'll say hello again. And we'll see. If she says hello, then she probably didn't hear me. If she ignores me again, that's going to be a whole other story, isn't it?
Well, no.
Or she prefers not, you said she prefers not to talk to me then.
Maybe she's not, it's not convenient for her. She doesn't feel comfortable.
Oh, maybe she doesn't feel comfortable. Well, there's another generous interpretation. Maybe she's not feeling at ease and doesn't want to be recognized, because we're here talking about depression and maybe she's uncomfortable. Exactly. But you can see the layers of interpretation, right? We don't know. All we know is that Edna didn't respond to my wave. That's all we're working from here. So it just gives you a sense of, now another person who is like, that Edna, I don't know who she takes herself for, and you can just feel like they're all pumped up. I'm going to go in there and give her a piece of my mind if she thinks that, well, you can imagine what's going to happen next, right? You're going to approach, and I don't know if we approach like this when we're angry. I'm kind of characterizing. But you can see the behaviors change based on how the narrative you built around those events. So the cognitive behavioral therapy is, I'm making it cartoon-like. But in reality, what we do is we work with people and we try to unpack these different situations that are contributing. So let's say, because it's not uncommon for somebody to be depressed after a significant life event. So it's often a combination of things, but let's say there has been some sort of significant life event, a loss or a change, and you like to tap into, how are they conceiving of this? How does this all play out for them? How do they perceive themselves now after this event has occurred that may be contributing to how they're feeling about themselves, feeling about life, feeling about their future? And it's really useful to highlight that and bring that out into the open, because most often we're carrying these stories around. We don't even know we're building stories. Like, we have a hard time distinguishing a story from facts. And that's a big chunk of what the CBT method works on. So it aims to bring these relationships out into the open. The other sort of key approach that we build into CBT for depression, excuse me, it's called activation, which sounds very exciting and a bit overwhelming when you're feeling depressed. So we don't call it that to people. But activation is really trying to reignite things that we know help people to get some lift going again, to start feeling good. So when people have stopped doing a bunch of things, then we need to help them start doing things again. So there's a lot of doing the work of how they're conceiving things, and also what are they doing and what do they need to do more of in order to get some lift in their mood and get some pleasure back in their lives, reestablish some contact with people that they need to have contact from. Because when you think about how we construct these narratives, I'm going to put it to you, how are your social relationships useful in how we're conceiving of things? Where do our friends and our families fit into that? How might they contribute helpfully or unhelpfully? to how we're conceiving of different situations. We have,
Well, it can help us do a reality check, especially people closest to us.
right? So the answer was they can help us to do a reality check, right? So when you think about, when I mentioned way back at the beginning, they tend to be quite hard on themselves, quite critical, take a lot of guilt, and a lot of guilt comes from a strong sense of responsibility, too much, often, right? And they're like, oh, and the whole thing fell apart, and it's all because of me, and now the whole thing's ruined. We're like, this doesn't all sound like it's all on you, right? So there's a little extra voice that says, time out, let's challenge that perception that everything is ruined because of you, right? Now, it's sometimes tricky because when we're a loved one, we don't get the same credit for our reinterpretations of situations. But if you talk to different people, when I say something to somebody, they'll say, yeah, my wife told me that yesterday. Right? So when you get more than one person saying, you're probably not entirely responsible for that huge thing, like the city of Montreal did not collapse because of something that you did. Right? So you get these new inputs. They can be challenges, they can be new questions, and the process we do to rework thoughts is through questioning. We ask questions. How likely do you think that that's true? Like, is that like 100% true? Is that like 50% true? What could be another interpretation of that same event? And so it's a lot through some of the things that other people would do informally. And so you get new inputs into your own thinking, because you think if somebody's depressed and they've withdrawn and they're thinking their own thoughts, like it's like you're drinking your own Kool-Aid at that point. And when you're not feeling so good, that's not such a good idea, right? Because you're probably just confirming in your own mind everything you thought in the first place, and that's probably not helpful. So when we talk about activation, we need to get people reconnected to other people. Like, what would your best friend say about this? What would your wife say about this? What would your husband say? What would your kids say to you about this? You're calling yourself terrible mom. Well, we don't always want to ask our kids if we're terrible. It depends on what decision we just enacted. But they wouldn't every day say that we're terrible and mean. Oftentimes, they would say, oh, Mom, it's not like that, right? We put so much on ourselves, and people around us would tell us the difference. Like, it is so not such a big deal. It really isn't. You go, so you come out and you talk to somebody and they say, it's really not. It's not that big. So it's a reality check, it's new inputs, challenging questions from people who are not depressed and who love you and who care about how you're thinking about this and can help you think about it differently. So activation is about helping people re-engage in things that are going to help them get some lift and get back into their lives. Because the ultimate goal is to get back to your life. Right? The ultimate goal is to go back to what your usual good self looks like. And so we try and figure out for them what are some of those things and how do we help get them back in. So some of the main components of CBT treatment, building a supportive relationship with the therapist, which is, apart from the therapeutic approach, the CBT part, in any treatment approach, the relationship with the person that they're working with has an impact. So for you folks, if you're thinking about how can I help, when you think about how hard it is to find a therapist and engage and find out if they'll work, one of the things you could do is like identify some resources for them and like read some blurbs about the person and say, does this sound like it could be a good fit for this person? And you could even call one or two and have an initial conversation and do some screening, like to try and make the beginning smooth so that they can connect more easily. Sometimes that helps because the relationship itself can be helpful. If they connect well, they're more likely to attend and engage. Rebuilding a sense of hope, and I put especially but not limited to the first depression, the sense that you can be treated for this and you can feel better again. So what you're feeling right now is not what you're always going to feel. And, it's some of the folk wisdom around you don't want to be making decisions and big conclusions when you're feeling like this way, because this is not how you always feel and how you always think. This is how you're feeling and thinking right now. So to get them to know this is what depression sounds like and feels like, this is not regular. And we're going to get back. Our goal is to get back to regular. In part through psychoeducation and experimentation that, for example, when we find out some of the things that the person likes to do, and we manage to figure out through a bit of experimentation and sometimes a little self-trickery to get back into it, that actually felt pretty good. You know, it's surprising how some little, like, I talked to somebody, I felt better. You know, so there is this, and then like you think if I felt a little bit better, I could maybe feel a little bit better than that. Like, and you just want that little sense of hope that I can feel better again. I feel, sometimes you mentioned numb, sometimes people stop liking things or stop feeling much about anything. Even little moments of feeling like, hey, that was kind of fun, gives them that sense that they can get back some of those good feelings. And even if it's not sustained, it's a momentary, but they have a connected feeling that feels good, that's something to build on to get back to feeling good more regularly. So, you know, one of the things can be good is you can remind people, like, they don't want to go out again. Well, that was kind of fun last time, wasn't it? I know you didn't feel like going, but like, what if we kept it simple and relaxed and short, and if you don't feel like it, we'll come back home. Like, just to kind of lighten up on the burden or the difficulty of it, but try to give them a little taste more of something that's fun without pressure. So that can be helpful too, to kind of get them going. Question? Self-trickery. Okay, well, what could that be? Well, so one of the question is, how do you define self-trickery? I'm busted for that. I kind of slid that in there and didn't explain. So self-trickery is, you know, people often think that they need to be motivated to do something. And some of the self-trickery is to, like, tell yourself, doesn't matter if I like it or not, I'm just going to do it. And if I don't like it, doesn't matter, but maybe I will. So you kind of talk yourself into trying some things, and it's like a little personal experiment. We'll see. I'll prove that therapist, and I'll show them that it isn't fun. That's okay. As long as you do it, and then report back, see how it went. But you try to, it's a little bits of self-talk and little, like, I'm going to go, like, here's an example. People are used to going to a big party, and that used to be fun. Now they can't even conceive of a party. So a mild little bit of trickery is, I'm going to go, but I'm only going to require that I go for 15 minutes. And if I still don't want to be there, I have permission to go back home. But the reality is, usually when you go for 15 minutes, you'll go for 30. And then you have enough time to go, that wasn't so bad. I didn't like get into wild partying, but that actually felt kind of nice to get out. And then you kind of build on it. So it's like bringing the expectations way down around having to feel motivated and do it like before and be excited about it like you used to be, so that you'll actually try something and then see. Because people often don't feel motivated and don't have the energy, so they'll usually, if those are the criteria, they won't go. So we try and mix that up to kind of get them back out the door. You had a follow-up.
Yeah, so if you talk about this as treatment, therapist treating is teaching self-trickery through the patient.
Well, yeah, so the question is, are therapists tricking patients? No, no. Are they teaching trickery? Well, yeah, self-trick. Well, basically what we're doing is that, and I won't go into it at length here, but anytime somebody is trying to form or break a habit, it's difficult getting started, right? So and oftentimes by the time we meet people, they've kind of fallen into, they're not doing stuff anymore. So there's a thing called activation energy that anybody, even if they're not depressed, struggles with to start something new. And there's all kinds of little twists and tricks and tips to getting past the difficulty of starting that we'll play with them on, and they can play with themselves on. I'm trying to think of what it's called. There's a book on habits, and I think it's called Habits. And it basically goes into the mechanics of how you set a cue and then how you respond to that cue and how you repeat, because these are normal habit loops that most people don't think about. But because starting a bunch of new things is so integral when somebody's depressed to getting restarted, we do a bunch of that with them because there's a lot of new little start points, and it's really hard to get started. So an example is that if there's something they are doing successfully, then you try and attach another good thing to something that already works. Or if there's a time of day, for example, that's much better for them, then you try and capitalize on that time of day to do the part that is most important and going to have a big bang, and you don't get them to do it at their worst time of day. So we do lots of experimentation and I call them tips and tricks to try and get things restarted. Yes, you had a question.
You know, when you just asked for an example, I was going to say when I wanted to start exercising again and I went to the gym, the trainer did that with me. I always had to have my bag ready. And then my shoes needed to be near the door. And then I just needed to put my shoes on, you know?
Right, so in any context, the example given here was of training, that if you were learning a new training habit, you know, your trainer would also tell you some tips on getting over the usual obstacles to getting started. So training is a great example because people, when they're not already training, are not motivated. They don't love it, right? And they feel out of shape. So when they move around, they sometimes feel briefly worse. Because it's like, oh my God, I'm so out of shape and da 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 da. And so, but you have this faith that I'm going to do this and I might feel a little bit better, even from the fact that I did it. Right, so that's one of the things we'll capitalize on, is that when people restart activities, they feel good for having just done it because they haven't done it in a long time. Sometimes the event itself brings a tiny bit of pleasure, which is useful, and just there's a sense of accomplishment. I've been trying to get to the gym for how many months, and I'm there. I only lasted 15 minutes before I felt like I might die of something, but I got there and I put in 15 minutes. So it's that kind of just trying to get things kicked off that we're working on with them. Can somebody give me a time check? 8:12. Okay, so I'm going to try and move it along so that we have some wrap-up questions, but I've been trying to weave in your questions along the way. Okay. So I just wanted to give you examples of what are some of the depressive type thinking, because there's anxious type of thinking, and you might know anxious folks are thinking a lot about the future and worrying about future things that are going to happen that are going to be dangerous or distressing or catastrophic. So each different kind of emotion like or disorder like depression or anxiety has its own kind of color to it. And here are some examples, and you may have heard referred to before, the negative triad or the cognitive triad of depression. And these are negative perceptions of yourself, of the world, and of the future. And so you can imagine how that plays out, how you filter things, because you're not seeing yourself very favorably. You often don't see people around you as very supportive, kind, compassionate toward you, and you feel like the future is not looking very bright, but in part because of both of those combined, right? So they're not feeling, so you can imagine how hopelessness and worthlessness can set in when this is kind of the filter through which you might be looking. And some of the important work is to recognize that if you took any of us and made us and doused us in depressive chemistry or depressive emotions, we would perceive these things. This is a manifestation of being depressed, right? This is how a depressed person thinks versus this is how it is. And that's the critical difference that we try to help people to understand, that how you feel is different from how it is, right? So when you can conceive of things in a more balanced, grounded, realistic, factual way, you are more able to see the difference between your feelings about yourself or the world or people around you and how it is. And that's an important distinction. And it's a difficult one because some people don't know that they've been thinking this way for a very, very long time. So it's difficult to distinguish that from reality. And that's a lot of the work that we're doing. Or I'm such a, so name calling is an example. Like one person will say, I'm very disappointed about how that went. So I had an event and it didn't go so well, and I'm really disappointed about how that went, versus I'm a loser and I'm terrible at my job. So you can see how big and global and negative it is. So, you can on your own, you can do some reading to hear about what are some of these kinds of phrases that you might hear from somebody who's feeling depressed, because that's different from I'm not happy with my performance, that presentation didn't go so well, versus I'm terrible at my job, right? Because it kind of gets big and negative and global. Others only care about themselves. The world is cruel, right? So you can see like terrible things happen, but often when people are feeling okay, they feel quite shocked about terrible things happening, but they're still able to notice that, hey, even when tough things happen, isn't it wonderful how people come to help and come to rescue and come to support? Like, I'm always struck when I see these tragedies that occur, you know, terrorist attacks and even local smaller events than that, and the outpouring of support and response and concern and compassion. So yes, cruel, difficult, terrible things happen, but when at some point, sometimes you struggle or can't see anymore that the whole world is not cruel even when cruel things happen. So you can see how it kind of colors the whole perception. Or I'll never get better, I will always be miserable, I will forever be stuck in this situation. And so when people really buy into it, to come back to your thought around when people, you know, may very well act, it's because they don't see that things can get better. They can't imagine a better future, in which case this is a lot of work for naught. And so that's one of the key pieces too, and we're hearing that kind of things will never get better. So very quickly, we want people to understand that when people are treated, things get better, right? So they're feeling that way now, and it feels terrible. But very quickly, you want them to have some experiences that show them that this can lift, that things can get better so that they don't become hopeless. You had a question?
Like a third point.
Mm-hmm.
But people who go to therapy or look for treatment, it's deep down, they know they can get better.
They know they can or they can't.
Well, they must do, otherwise they didn't go for treatment. But what about someone who can't conceive of, you know, have you said to a person, you could go and get better, but they're at that stage where they're thinking, because it's been like that for so long.
Right. So the question is, you know, it's one thing when people have gone to therapy because on some level they believe it maybe could get better, or they wouldn't seek therapy. It's much more difficult when somebody has thought this way for so long that they are not amenable to it. They can't imagine that it could be better. Well, I mean, there isn't a neat answer to that or a tidy answer to that. But I have, you know, the examples that come to mind, hopefully not stereotypic, but for example, my clients will have people in their family that, for example, a family business, and people work closely together and they work with their parent in a business, and they themselves were depressed, and the two of them thought the same way. And so, you know, this is just how the world is. Everybody's stupid and unhelpful, and so both of them are angry and depressed and upset all the time. But one of them is influenced to go and seek treatment or get some inputs, get some consultation. I'll say often they will consult, not necessarily engage in a full therapy process, but enough to recognize, hey, a chunk of this is me. And so sometimes they'll be influenced by another close other who has made changes in themselves, and then not on purpose necessarily, but sometimes on purpose, will influence the other person to show them, hey, I thought like you too, but I realized a lot of this had to do with what I was doing and how people were reacting to me. And so that can kick off a change, or reading something can kick off a change. But it's often a loved one or an inspirational person, like somebody important to them, will show them that things could be different. But it is tougher when it's been, this is just how you think the world is. Yeah, it gets more enrooted. Okay, so I'm going to try and... A guilty thinking style is another one. Guilt is often very common also in depression. I should have known better. You can see the shoulds. Like, it's a very heavy kind of thought and very self-blaming, right? Like, not only did this thing happen, I'm fully to blame and it's all my fault. And you know, as opposed to taking normal accountability, like, I didn't study enough. Right? That happens. That's the truth of the matter, is I didn't get much studying in and I didn't do so well. I mean, that's factual. Versus, what was I thinking? And obviously I'm self-sabotaging, and it goes into this kind of more global perception of I'm a bad person for not having done well on an exam or a paper. It gets too big. It gets too far past the immediate situation, which tells you you're boring from other situations. So kind of guilty. Some of the challenges to treatment, and then I'm going to talk about family members and then I'll stop. What are some of the challenges? Energy and motivation to find and engage in help. So if you're depressed, it's not easy to get out and get help. You're having a hard time meeting the demands of daily life sometimes. And I think that's a key role for where family members can help do some of the legwork or some of the initiation to get things going. Hopefulness that things can get better. The sense that this can be treated. And, I'm just thinking about the question about people for whom this has been a long time. Sometimes it's a physician also who will say, this is treatable. This, what you're suffering from, is treatable. And so getting them information about, treatment and treatment effectiveness can also help. They believe in their thoughts. And they don't think that they're thoughts, they think they're facts, and they're confusing the two. So some of the work is trying to give them examples of like what the facts are versus how you feel about it. Engaging in treatment so that it can help. So if this depression is severe and longstanding and we're not achieving lift, sometimes it's so severe they can't engage in the treatment itself. And that's where we think about whether or not medications might help to get enough lift going to engage in treatment. Breaking isolation after a period of withdrawing from everybody. So, even coming out to meet a therapist and talk with a person that they don't know, that's pretty tough when you're not talking. And to be able to be influenced by people who love you because you kind of made your world small because of how you're feeling. Taming the thoughts and developing new views of yourselves. Even if people can't develop a new positive view or a new, confidence, that they can at least rein in the self-critical thoughts is a really good start. Because you think about you're not feeling good and then the self-critical thoughts and the blaming are heaped on top. You can feel yourself sink down. If you can at least start to challenge and even neutralize some of those thoughts without thinking you're great but not thinking you're terrible, is a start. Noticing patterns that help and those that undermine to remain watchful and protective. So some of the challenges, even noticing what you may have let go of that could have contributed. It's all very useful in the long run to see where did things start to fall off? What did that look like? What were the early contributors to this so that we can turn things around? Sometimes people don't know on their first go round what all, so it takes a bit of time to unpack all that and identify what some of those things are. All very achievable nonetheless, but these are some of the bumps that along the way. It's positive, yes? Can you give me an example? So the comment was, hey, that all looks positive, not like challenges. Can you give me an example? Oh, the challenge is that they might not have it because they're depressed. Right. Yes, it's maybe just how I worded it is, yeah. So somebody said, hey, it's great if they found energy and motivation to go to therapy. But that's the challenge, is sometimes they don't. And that's where you guys might come in. Right. Lack of hopefulness and lack of energy. Right. Yes. For future reference, I should put lack of at the beginning of each of those points, because he's like, this person's doing fabulously. What is she talking about? Good point. Yeah, I'm a bit of a positive worder of things. Yeah. So that's a good point. My wording was rather optimistic on this. I try to think of it as a quality rather than a character flaw, but sometimes I don't see stuff like that. But thank you for letting me know. How to find treatment. So, pardon me, are you making negative interpretations over there? Well, that's what I was saying. So the person said, oh, I'm such an idiot. We don't permit those kind of global negative self-statements in here. We all know, but you know what? You'll have gone home, you'll have squirreled away that one thought about not making those, I hope, those negative global self-statements. And I'm pointing at all of you. Store that away. So if you want to find treatment, I mean, obviously I have a bias for the cognitive behavioral treatment, but I went and sought out that particular approach to treatment to learn about it because of its efficacy. So, if you can just put in depression and CBT, and you'll start to see resources pop up. You can also go through, somebody that who's been treated before and liked the clinic or the person that they worked with. The Board of Psychologists or the College of Psychologists also have search engines where you can put in where you are in the city and what you're looking for in a therapist. So there's a lot of resources out there that you can find pretty readily. What I would suggest is, if you're trying to help somebody, is to do a bit of screening, because that's work. Right, is that finding of a therapist is work, and you helping out with that will lift the load and would be one of those things that'll help get people in. Through community organizations like this, I mean, they often have a bank of recommended clinics or therapists, so this is another good example. And your family physician. I would say that the balance has tipped a great deal, with self-referral taking a bigger percentage than it ever used to, but GPs are still a big source of referrals because they have trusted clinics that they work with, that they know that, and when a person has a good relationship with their GP and they trust them and the GP says, go here, go do this work, sometimes that's enough to get people over the hump of taking this step. How can you help? Learn about it yourself. So, for example, like you're doing tonight, what are the symptoms? How is this different from situational or just having a bad day or having a bad spring or waiting for spring? How is this an actual diagnosis? So go and inform yourselves and know what you're watching for. Observe over time. So give yourself some time, not an eternity, but watch to see if it persists, and watch to see how different this is from the usual for this person. And prepare to talk to them. Like, if I know maybe they're going to get mad. Sometimes they get mad. I've tried this before and somebody got mad at me. Right? But ultimately, I'd rather they got mad at me and I tried to help them than I don't say, because they might get mad. I'm willing to take that hit. Or if they say, no, actually, you know what? It's just been a really busy period. It's been 3 months. We've had no breaks and I'm just exhausted. And I can see in myself that I'm not my usual self, but I'm fine. I will take that as a cautionary wait and see. And then I'll just see if things improve, and if they do, fabulous, right? So, so what if somebody gets a little upset with you and you can come back and say, you know what? It's just, I was worried. I saw a lot of things that were different. They're not you, and I was concerned. And if that, makes them upset, then you can talk about it some more with them, but it's worth taking a chance and them being a little bit unhappy with you so that you can help. Learn about how you may be inadvertently contributing, and all I mean by that, because not to say that you're causing this, nobody's being accused of anything here, but sometimes a person naturally withdraws and they want you to withdraw with them, and you know what I mean? So they want to stop doing stuff and they want you to stop doing stuff and stay with them, and you realize it's not good for them. And so sometimes inadvertently, because they're not feeling too good. So somebody mentioned, if somebody sleeps a lot, should I let them sleep a lot? Or do I intervene? So, because it's tricky, you don't know what to do. So part of that is, how do I cut them some slack and give them some space and not be tough on them? But I also want to make sure that if I can help them, a basic simple thing is get them out for some walks. Like small amounts of exercise. You don't want them sleeping all day. That's not helping them, because often that's disrupting their sleep at night. So if they sleep more, then, that's understandable, but really sleeping a lot, you can say, you can have another rest later, but let's go do something really simple. Like, let's do something light, or let's just go for a short little walk, or that kind of thing, to try and help them get restarted on things. Or if they're refusing, no, I don't want to see anybody, at some point you want to encourage them out of the house, because they're not going to feel better by staying in the house by themselves, especially if they're not engaging in treatment. Learn about how you can be more constructive, talking or walking with them, giving them new inputs, reality checks, gentle, compassionate challenges to their perceptions of things without making them feel worse, but just saying, yeah, that doesn't sound like entirely your fault. Like, I get part of that, but I think you're being a bit hard on yourself. Like, just an opinion. Help them locate clinics and therapists. Encourage and support them through their treatment. So somebody had a question about, how do I know what's going on in treatment, or how do I help them through a treatment process when I don't know what's going on in that session, right? Because it's confidential, so you can't ask, intrusive questions about it, but you can open up the subject and say, how's it going? Are you finding it useful? Is there anything I could help with? Like, and I often say, like, if I was like the loved one, if it ever comes up that there's stuff I'm doing that's not helpful, that's upsetting you, I'd want to know, because I'd be open to hearing about it if I could make things better. Because often that's the worry, right? How are you doing? Is it working? Is it helpful? You can ask those questions, right? Is it me? But you don't want to say, is it me? But you want to say, hey, like, if it turned out that I had something, to do with this, like, I'd be open to hearing that, right? Because maybe they are talking about you in therapy, and I'm not trying to make you paranoid, but it could be that something that's happening in the family or in your relationship, they're perceiving in a way that's upsetting to them. Well, I'd rather know what that was than just be wondering what's being talked about in the therapy session. So you don't want to be invasive, but you're allowed to ask some general questions just to open up the conversation. And I often say, I'll also tell you that when I'm talking to my clients, I'll tell them, it wouldn't be terrible after therapy because they are often talking about their key relationships, to, leverage off of therapy and say, this thing came up today in therapy, because it's hard to open up on something that's not been talked about in a relationship before, to say, this thing came up in therapy that I wanted to talk to you about. And we can prepare them to talk to you. So if you're also preparing them to say, I'm wide open, they might say more. Yeah.
Will it happen often that you'll try to convince them to have, let's say, a family member to come in?
Will we often?
In a session with your client, let's say?
Before I repeat the question, I just want to clarify the question. Is it often that we encourage them to bring somebody?
Yeah, I'm saying, does it happen often, or it's something you stay away from, like, as a therapist?
So as a therapist, do we sometimes encourage their significant other to come?
Or a parent, let's say a mother, father, spouse, or...
So, or if it's a parent or of maybe a teenager or a young adult, not uncommon. And especially if our sense is that they need to engage another person in the family. So is it common that we would engage somebody else? It's not uncommon. And especially at the beginning, because it helps them to get in and get started, or if they're a very pertinent part of it and we have a sense that the person's not able to make the link over and bring the person into that conversation, I'll often volunteer to facilitate. How can I help you have this conversation with that person? Because then it opens up that conversation and they can take it from there. It's often really useful. I don't shy away from it as long as that client is comfortable enough. And if they want the other person to know and they're struggling with having it, oftentimes they'll go, yes, please. So like everybody gets to open that up, so then we have all the right people in on the conversation. And take care of yourself. It's not easy supporting somebody. I mean, somebody mentioned a particularly hard situation where they're supporting somebody who's sick and gotten depressed themselves, but it can also help in that if your partner is depressed and for long enough, you can start to see symptoms in yourself. So you want to get your own support. And it can happen that what you're figuring out for yourself can be useful to your spouse. Sometimes they will trust you can be a good coach to them without them going to therapy, and they'll see the benefits through you and maybe even will engage in treatment themselves. If you've not been very successful in getting them into treatment and you see you're starting to struggle, even if you're not depressed, it's good to go and get your own support. And I've had many clients who consult, so they're not really in a therapy process, but they consult a professional because they are trying to have important conversations with somebody who needs to be treated but who's not open to it. And that helps them with, how could I try this? How could I try that? What about this? What about that? And they're getting their support to shore up their energy and share up their stores. So I think that's it. Yep. Yeah.
Increasingly firm.
Okay, so what does that mean? What does increasingly firm be? Well, at some point, I mean, you're saying in the early days you're much more light about it. So could it be helpful to talk to somebody? And so, you know, in the early days, you're trying to invite, encourage, influence. At some point, if somebody is clinically depressed, they're not leaving the house, their mood is sinking, and you're concerned about them, then you become more firm around, we really need to get you some help. Like, we can talk to, and they were looking at options. We can go to the doctors together. We can go there. I can go to a clinic with you, because it's like at this point, you need to secure their safety. They're sick. Like, and if they had some other, it's true that other people could have other diseases, they also won't get treated. But when it comes to an emotional disorder, people will sometimes neglect that more than a disease of some other kind. And at some point, if somebody had something else they weren't treating, you would say, come on, at this point, like, we can talk about how we go about it, but we need to get you some treatment. You know, here's what I notice, here are my concerns, and the tone of the conversation changes. Still not critical and still not harsh with them, but to say, and that's why I say the word firm, but saying we need to do something about this. I'm very concerned, and let's talk about how we can go about this and find out what their concerns are or their preoccupations. Like, what are they scared of or what makes them most uncomfortable, and try and remove as many obstacles as you can. So I think that's it for now. I tried to weave in your questions along the way, so I hope I've addressed them. Here's a few references. Now, I understand this goes on your site after, so if you don't have time to copy these down, they will be available to you. And you have these, and there are some of these available in the office if you would like to borrow them. Okay. And I'll stick around for a few minutes, because I know I didn't catch every question, but I hopefully got to a bunch of them, and I can catch a couple at the end.
Well, thank you very much, Francine, Dr. Francine MacInnis. It was really great, really helpful, and I like your approach, very friendly.
Thank you.
Thank you very much.
Very welcome. Very welcome.